I wanted to start with is that when the law was amended in 2014, there was a lot of attention being paid to the costs of treating babies who were born with neonatal abstinence syndrome. And I wanted to ask each of you from your different perspectives, what are the costs of a policy like the one that's currently in place? And those don't have to be restricted to the financial costs. Is that on? Okay.
So what are the costs of a policy such as this? Well, there obviously are financial costs. I know in Knox County, where I live, they built a wing onto the Children's Hospital there to treat neonatal abstinence syndrome specifically. So as far as financial costs, it's high, but I think that there's more of just a social cost even, because there are root problems that are not being addressed, and there's just going to continue to be more and more women who struggle with addiction, struggle with maintaining sobriety or recovery if there aren't preventative measures. So obviously prevention would be the key and the most optimal solution, because that would prevent a woman who was using while she's pregnant before she's pregnant. So I think, I think prevention is the key for that.
Yeah, and I would just kind of echo what Rachel had said, but I think that in terms of social cost, you have this idea that you're putting into people's heads that you can legislate women's bodies and kind of the whole idea of the mother and the child, and before the child is born, and kind of perpetuating ideas about that. And when you're not focusing as much on the care of the person, you're valuing one over the other in that case. So that would be my answer to that.
I think a couple of things. I think at first I'd say the cost of the criminal justice system. I mean, picking up where Zach left off, we treat so many things these days with the criminal justice system that was never designed to do so. Mental health is a very good example. In Tennessee specifically, we've closed down and defunded so much of our community-based mental health services that Shelby County Jail is the largest provider of mental health services in our community, probably in the state. And so when we begin to take on other social issues, like women using drugs while they're pregnant, with that criminal justice system, we further undercut the value of what is the best way to handle crime and punishment that anyone's ever come up with. It's very broken. That's a whole other conference, right? But by doing this, by continuing to use it to treat people's homelessness, to treat people's mental health, to treat people's addictions, we take away from what it was built to be, and that is an adversarial system where your rights are observed, protected, you are given an attorney, you are given a process. And we introduce women, I was just looking at birthdays versus arrest dates, 8 days after she gave birth, she's arrested. And when we introduce that and that set of issues to someone who has not been violent, to someone who is addicted, we're just ripping apart the criminal justice system even more. We're putting pressures on her that were never intended to be put on her. Breaking the law is a serious thing, and you have decisions to make. We're introducing incredible pressures that have nothing to do with what this criminal justice system was, how this criminal justice system was designed to work. And I think that those costs are really maybe unspoken.
Yeah, not only is there a societal cost, but there is a clear financial cost. If you just look at it's 70 something plus or more, depending on where you look, dollars a day to incarcerate someone. Yet they could get standard of care treatment and an opiate treatment program for between $12 and $15 a day. So our society is choosing to incarcerate them when we could give them treatment for, I can't do the math in my head, but that's a lot less. And, there was research that came out of California, the Cal Data studies, that show for every dollar invested in a medication-assisted treatment for opioid addiction, you're going to get back, and it depends on, which treatments you're looking at, but for medication-assisted treatment specifically, for every dollar you put in, you're getting more than $10 back. Some show as high as $30 back. The in community is getting back, mostly reduced incarceration costs, but also we keep one in IV drug user, if we get them in medication-assisted treatment from contracting HIV or hepatitis C, the lifetime costs of treating those conditions, it blows my mind that a supposedly fiscally conservative government in our state is making decisions that waste and spend more money on this issue. When we have research data, we have solid facts, on what to do. Yet our TennCare coverage will not cover the standard of care for opioid addiction. We have this prescription for success that's out right now, and not $1 goes to the standard of care treatment, not $1. And so, there's a societal cost, there's a cost of lives, there's a cost of families, there's grieving families, but there's a real financial cost to our state as well. A teensy fraction of what we're spending in the criminal justice system right now could go to providing standard of care treatment for every opioid-dependent person in the state that needs it, and we would still save a ton of money. It's irresponsible.
I can give you a few figures from New York. Anyway, we just recently passed legislation to have medication-assisted treatment in the drug courts in New York. The problem with the law right now is that it has the word "may" in there, so it's still up to the judge's discretion whether they're going to use it or not. So we will see what happens with that. But along with that legislation, what was printed on the Senator Murphy, who was the head of pushing this law through, on his site, they had said that there were 85,000 participants in drug treatment court in the state, and that's since it started. Out of that, more than 50% of the participants failed. So if you look at the cost of them going through this treatment that is not working through the criminal justice system, and another more than 50% are failing and are either incarcerated, because that is what happens when you fail drug treatment court, or are dead, then the cost is really something to look at when it involves 85,000 people. And that's one state. If you go state by state by state and then duplicate that, at which the studies have never been done and the cost analysis has never been done, I think everyone would really be surprised and would be motivated to say, this is a medical issue. Why aren't we dealing with it through the medical community instead of leaving the care to the criminal justice system? They have no expertise in that area, and they're allowed to run rampant.
Say one more thing about the social cost with Public Charter 820. I'm a clinician. I work at a substance abuse treatment center, so thinking clinically about the implications and the social cost of this, specifically thinking about trauma, which is something that we heard about in the presentation before this. So in talking about the child, separating mother and child is further exacerbating the problem of trauma and potentially harming the child later on, setting them up for greater lack of coping skills, more potential to have mental health issues. So not only does that financially cost to be in the foster system, but also just the social the social cost of separating mother and child, and when the mother is incarcerated, when recovery is an option, and families being together is an option instead of separation. I just want to point that out.
What is the greatest challenge that you see to achieving justice for drug-using pregnant people and for drug-using people in general?
Yeah, I think the greatest challenge is and I was thinking a lot during Dr. Abraham's presentation, a cultural change that will have to happen to be able to have policies and to fund programs such as intensive case management or hospitals that are able to, community hospitals that can offer wraparound care and support for mothers and families. And I think that's a huge challenge, is getting states and getting policymakers to a place where they can stop viewing women and shaming women, and moving to a place where we can say what is a root problem and how can we get to that. And I think that's something I think about a lot, especially in substance abuse. Having come from working with substance abuse users in an institutional setting in the criminal justice system. I mean, it's just not just for pregnant women, but also for people who are indigent and don't have any way to pay for something, because we hugely lack resources in this state. And are losing resources in the state for indigent care. So I think the cultural problem is something that is challenging and we'll need to work through.
I'd like to echo that as well, and part of the problem too is the attitude and the stigma that surrounds people who use drugs and people who are in recovery. And until you bring those two groups together, because it seems that even those that have recovered in their terms, once they've recovered, then they no longer feel that they're a drug user, and they discriminate against those that use. So it's not only that, yes, you want prevention, and yes, you want these programs in place, it's also a total shift in how people are viewed. And as the lunchtime speaker was highlighting, it really is an attitude. It's an attitude and a change with physicians, with emergency personnel, with police, and even within families. You know, you shame each other in a family situation as well. You're taught with AA to detach, which is contrary to a mother-child relationship, which further stigmatizes people within their family. Whereas if you were had cancer, or you had anything else going on in the family bonds together, they help each other. And if you're a user or you're a recovered user, you still have that stigma when you go home for Christmas, or Hanukkah or whatever. And it is definitely a cultural shift.
I think data is going to be part of what drives these types of changes as communities, as a society. And what we found when they sought to expand this law in Tennessee last General Assembly was when we showed up here in Nashville, no one knew what had happened since the law went into effect. I mean, I am not a statistician. I do not collect data for a living. I do not know how to look at data. I'm a lawyer. That's why I went to law school, because I don't do numbers. But we had the largest body of any sort of actual figures in the state when they came to expand this. And we're measuring things in the drug court in terms of recidivism, in terms of whether someone gets rearrested, not in terms of their health. So there we are again, using a criminal justice metric to gauge how well we're treating someone's health. And so focusing on measuring the right things, I think, will help drive some of these cultural shifts. And so when we pass a law like this, we also pass a part of that law that says, and this is how we're going to measure it. So when we come back to see whether to sunset it or not, we know. And we haven't done that.
When you're collecting the data, the biggest thing with data collection and the math that's involved in that is, are you asking the right questions? And are you collecting the correct data? Because if you look even just on the drug courts, they may evaluate it out 1 year and they make a published report and everybody thinks that that's fine. Well, you're on probation for 5 years. So who's doing the study on these people for 5 years? And if their goal is that they're in recovery, they have no idea if 10 years down the road, whether they're in recovery or they're not. There's no statistics out there whatsoever. So they don't even ask the right questions when they're collecting data. They collect data that we don't need.
I mean, it's a cultural change for sure, and there's a lot of things that have to happen, but as far as something that I see in the advocacy role that we play for people who are either in treatment or seeking treatment is for our legislators in this state to try to help us realize true parity. The Mental Health Parity and Addiction Equity Act has finally, it was under the Bush administration and the Obama administration, finally fully implemented it. That's pretty bipartisan, but what? It has no teeth if the states don't really enact it. Like I mentioned earlier, our Medicaid program, TennCare in this state, even though it's federal dollars, it's up to our state to allocate it, will not pay $1 for someone to go to an opioid treatment program. And then we act like we're serious about confronting this prescription pain pill and soon to be heroin epidemic that's on our doorstep. And indigent folks just can't pay for treatment. With parity, thankfully, the combination of that and some of the laws with the ACA, some of the private carriers like Blue Cross Blue Shield of Tennessee, after a history of discriminating against opioid treatment programs, are finally starting to at least reimburse patients that are seeking it on their own, but TennCare does not. And so I think true parity, if we, that people who deal with substance use and mental health conditions, if they are seeking what is known as the gold standard treatment, the most effective treatment for their condition, yet our Medicaid program will not cover it, I think that's a big first step towards justice.
One of the, or if not the most important part about changing the stigma is helping these women learn to love themselves and know that they are worth it. They are worth recovery, and they are worth living, just having a life. I think that the first way to do that is going to be to create more services for treatment for these women so that they can get in recovery. And then at that point, my hope and vision for what could actually happen is, for a more participatory style. So for women who are in recovery to support other women who are pregnant and help each other. That's been shown, to work time and time again in different treatments, group therapies. So I think empowering these women is going to be a challenge because we do not have enough recovery resources for them, but also very important in their sustainability of recovery as a group. So.
I'm going to add one more thing that I had thought of while they were talking, but I think another question that we have to answer is, where's the point of entry going to be for services? Right now, for mental health services, for housing, for substance abuse services, the point of entry for social service providers is like jails right now. We're in jails, and that's how we get people to treatment the first time. That's how we get people to mental health treatment and get them housed. And so how are we going to change that kind of point of entry, or where it should be out in the community? It should be in medical care facilities, and that sort of thing. So I think that's another question as a social service provider myself that I have to think about. How do we change that, our thinking about point of entry, instead of going straight to the criminal justice system to find those people.
So I hope y'all will indulge me just one more question, but it's a quick one. So you've all painted a picture of a system that has a lot of broken places and dysfunctions. And so I'm wondering, if you had the opportunity to address one person or player in this system and ask them or tell them anything you could, who would you want to speak to, and what would you tell them or ask them?
I really think it's the acceptance from the medical community. My son was very lucky. He had a personal physician and a family physician where my son could talk, and he could say when he started using, and he was very well taken care of until, even though he did relapse here and there, he held a very stressful job. He was highly educated. He was a very good citizen. He was a wonderful son. But he was lucky he had a good doctor. I know what happens when you have a poor doctor, or when you have the criminal justice system stepping in as doctors. And I think with our panel up here saying that it's the community support and getting those people on board to accept those that are using, that will make the change. Because if you start to talk to your doctors honestly, then you can put in educational and prevention and listening and being taken care of. So that's where I would start. The laws, that's just going to take a long time to change.
I would like to talk to funding sources, so state and federal funding sources, and what I would ask them is to fund recovery centers for pregnant women and make that a priority in our state and in our country, so that pregnant women can get the help that they not only need but deserve.
I think, see a camera, some hashtags, and I might get in trouble. But I think specifically to this law, I think the person that I would, when I face the question head on, would like to speak to would be the District Attorney General of our county, a woman who helped support the passage of this bill originally. And I would encourage her to watch this and maybe go through some of the tweets and listen to some of the highlights and listen to the pleas for help that have been made from this stage for women's health and not criminal justice, and creating more people with criminal records. And because I think a voice like that is instrumental in getting this thing tucked away forever where it belongs. It should be noted that the District Attorney General of this county has not pursued a single charge under this law. So I think those voices, specifically hers, really go ahead. And I may not have a job, but it's my job to harass the district attorney.
And that was exactly going to be my point to adjust. But I've had the experience of working in a rural county with the prosecutors and the victim advocates and that sort of thing. And the way that they view it sometimes is really can be bullies. And I don't think they do that intentionally. I think they do it because they think they're doing something good. But I think that's also misguided. And again, I would encourage, watch something like this, read some papers and some journal articles, and figure out best practices and what we can do so that you can work with people, and outside of this law, just people who are experiencing substance abuse problems, who might actually be charged with something else. What are ways that public defenders and district attorneys can work together for restorative justice?
One of you has already tweeted.
I think that it starts, the advocacy and the treatment community, a lot of folks that are gathered here, whether you directly work in treatment or you're just advocating for folks, I think it's gonna take us starting to get along, because for too long, it's been the abstinence-based model or the medication-assisted treatment model, and then mental health is a totally, and until we can all start realizing, and I've talked a lot about methadone being the standard of care and the gold standard, and those are all true, but at the same time, I support all options that offer help and hope, whether they be abstinence-based or include the use of medications, whether they're residential, outpatient, whether they're short-term or they extend for months or years. And I think that's what the conversation has to center around, that we have to start talking to each other and realize that nothing works for everyone, but something's going to work for everybody. And I think that, so we have to kind of get our house in order. And then, and we've got to engage our legislators. It's very encouraging that we have some here today. That's kudos, bravo.
floor. And so one thing I wanted to ask is a related issue is that uncompensated care in Tennessee has already caused 4 rural hospitals to close. And that puts added stress on the neighboring hospitals. That puts added stress, Zach, like you said, on moms who have to drive hours to get care, if they even decide that they want to risk it. And so I wanted to ask and see if you all have any opinions on what the coverage gap, the effects the coverage gap is having on pregnant moms, especially undocumented individuals in Tennessee.
I don't have any figures on the pregnant women, but I do know what's happening in other areas. And what parents are doing with their kids is they're hoping they get arrested. They're hoping that they get arrested and they get their treatment through a drug treatment court, because then it's forced. So I don't know if it's not a solution, and in fact it's a horrible solution, but I think some people are desperate and for care and they can't get anywhere, and when they see that the criminal justice system is the solution, they try to get into the criminal justice system. That's just kind of an observation, and it is an observation that I have had plenty of emails about as well. And it's really scary to think that you're going to a criminal justice system for your medical care.
Something that we've seen with pregnant women who, I've mentioned they, in this state, where they're, especially if they're low income, they're self-pay at opioid treatment programs. And so because they're on a maintenance medication, most treatment programs, well, all the ones that I'm aware of in this state, in most states, they're not going to, even if the woman is unable to pay, they're not going to taper her. They're not going to, she's going to stay in treatment. So she could go 9 months or 8 months and 4 weeks, right, you know, without pay for treatment. And then, but once the baby's born, it comes back, you know, she's got that huge balance, and then they end up being, we call it detox, that's our word, because they're not, you know, they're detox for not being able to pay. And so then what happens is you've got a mother caring for a newborn that's in withdrawals that often ends up back up on the streets and back in the drug using cycle. And so, you know, it's the issue of parity. It comes back to that again, whether someone's pregnant or not, but especially for pregnant women, because even if they can get treatment for those 9 months, they got a baby to care for, and they don't always make it afterwards if they build up, you know, that kind of balance. And so,
I will say something very quickly about that. I don't know a lot about pregnant treatment, specifically in my practice, because where I work, we do not treat pregnant women. And that is unfortunate. What I do know is that a lot of pregnant women are going to be on TennCare, and there is a great coverage gap between TennCare and private pay insurance. At my place of employment, we treat a very small percentage of TennCare patients. And the TennCare patients that we see not only struggle with different issues, generational poverty for being one, it's a deep, very serious deep issue, but then the private pay people that we see. But also, because the treatment center where I work, it does not benefit financially, so it's a for-profit treatment center for TennCare patients, and therefore does not have a motivating factor to continue to treat or treat a higher percentage of TennCare patients. So if there is, in theory, a treatment center that will take pregnant women, if they are on TennCare, it is going to even lessen their chances for getting into the treatment center.
So I saw a hand over there. While Laura gets over there, we can take our, on this side over here.
Good afternoon. Steve Petty, Tennessee Commission on Children and Youth. And just a comment, on Tuesday I was at a meeting, a group with the Bureau of TennCare. And they're talking about several issues. They're going to start going through the re-verification process, which was the issue I was most interested in. But the first issue they brought up were some of the budget cuts that occurred in the current year's budget. And the primary cut that they were there to talk about takes effect today, October 1st. And ticker patients will be limited to 24 months of Suboxone and those other two drug drugs that this country won't even pronounce. But anyway, that's effective today, and it will be retroactive to the fact that if they have been on Suboxone, then they're still limited to 24 months, and they will get 6 more months, and then their coverage for Suboxone will end.
And
So, I mean, I had no reason to be there, and I didn't know why I heard that, but I know that. So I can tell you.
that is for, TennCare will cover Suboxone in an office-based, there's a special law that allows doctors to prescribe Suboxone. It will not cover it in a comprehensive opioid treatment program, which is where you're getting counseling, group therapy, but you can go to the doctor and get a script only, no counseling or anything, and they will cover the prescription, but that is what's being limited to 2 years, and it's still a tragedy. Because, the National Institutes on Drug Abuse, we've got study after study that shows longer treatment times yield better results. And so in the midst of an overdose epidemic, we're going to suddenly cap an evidence-based treatment to 2 years when we have tons of data that shows longer treatment times yield better results. Some people might be able to stabilize and taper off in 2 years, but the vast majority won't, based on what without relapse, that is, based on the data that we have now.
Over on this side.
Thanks. I just had a thought that this could be the long way around, and a blessing that we're here talking about this today, because I think I don't know that necessarily our state policymakers value drug-using people. Would we be having this kind of conference about that, or even women, or drug-using women? But they value babies, right? They value babies, and they value money, which is costing too much money to treat the babies. That's why, I think that's why we're here. Because this was an attempt to address a financial and health issue that isn't really what we're talking about today, or at this panel. But I guess my question goes back to what you said about, the data, tracking the data, what are we measuring? And if this was designed to address the NAS problem, are we addressing it? Do people know what the NAS numbers are? I don't know what the NAS numbers are. And I don't know what the NAS spending is. So I don't know if this is the right panel to ask that of, but does anybody have any information on that?
When we've tried to find NAS data, that and like overdose rates, all of that type of data is so county by county that some counties just really they won't release it, or some of the ones that I've tried to get it from, I'm convinced that they don't really track it. And so to answer your question, from my experience, which is very subjective in dealing with the certain counties in East Tennessee where I live and those surrounding where I see the most advocacy cases, is we don't have data. We have limited data here and there, but we don't have those numbers, and I think that we need those numbers.
I just want to warn you, we have about 3 minutes left, so this will probably be our last question.
Well, just to respond to one of the speakers at the symposium, we were talking beforehand, and he was suggesting that at least the increase in marked opioid use peaked several years ago, at least that comes from pharmaceutical companies and from doctors. So we're seeing a very belated response to something that may well have peaked several years ago, and I hope those of you who stayed for the symposium will hear that. And then part of the problem about how to answer that question is how is NAS diagnosed? And are we seeing the costs, not because NAS has an objective cost, but because the way in which babies and mothers are separated increases those costs? And I know for a fact that when I've asked Dr. Patrick in his study that evaluated the cost of NAS, did he ask what the hospital policies were? Did they have rooming in? Did they allow breastfeeding? Did they use any of the techniques that reduce the symptoms and so forth? And he said we did not ask that question.
And
I was just going to say, with the plateau, prescription opioids have largely plateaued, but heroin is not. We're starting to, it's continuing to spike, and I think that's an important distinction to make, because what's happened is, in laudable attempts to crack down on unethical opioid prescribing, we've closed down a lot of pill mills, but we have not referred those people or provided access to treatment. And so what we're seeing is, yes, prescription opioids have plateaued, and now we've got a heroin epidemic on our doorstep because we haven't gotten those people into treatment. We've just taken away their scripts.
Yeah, one last one, bring us on home.
Okay, so one of you mentioned that in Davis County and I know in some other surrounding counties, we haven't had as many arrests for this law. But anecdotally, I'm in research and evaluation, and it seems there's a lot of families that are being involved with DCS because of testing positive for substance when they're pregnant, give birth, as well as their child. And I was just wondering your thoughts on that, and possibly if anyone who is sort of on maintenance treatment has been sort of put in that, right? So you can be on a legal drug that's prescribed by a doctor and still be considered putting your child at risk. And so just what are your thoughts on that?
And it depends on the DCS worker. When someone tries to come in and will educate them, a lot of times, it's case closed. I think a lot of it is not malicious. I just think there's a lack of education. Same thing with police officers. They don't know about maintenance medications, and it's a Schedule II controlled substance. That's what they see. So to the DCS part, it varies, but there are some federal court cases that have set precedent on it, but it varies widely.
I would say quickly that that's a great point, that using this hammer in the criminal justice system has implications that we don't even know about, and it could be driving very well involvement of other government services into people's lives that wouldn't ordinarily be there. The families would, circle their loved one like we try to do and not involve the government. But that's a great point, and it's just having that out there is certainly driving behaviors in the direction it probably should.
So we actually are going to have one more question. Senator Tate?
You have to call my name. Just let me stand up and say my question. I don't have a question, but I do have a statement that I would love to make. Thank you all for the evening. I have learned more from this than you think that I ever would. And it's not that I was interested in learning, but I'm glad that this has provoked such a response. And it gives me more area to play in than you would know. Also, I'm limited in areas that you wouldn't know that a politician is limited in as far as some of these answers. And Elaine, I would like to compliment you from wherever you came. You have articulated it and wore it well. You have the right language and you have the right expressions for what you've done. I think you'll be a lot of help across this United States. And so the rest of you guys call me. If that lady that tries to drive 2 hours or 4 hours, I can stop that one. But let's say some particular issues as it relates to this bill. I avail myself. There are some areas I can go that you cannot. We can open these doors, even with the judges. So now I'm going to turn my back for you. It's the bullseye. Throw now. Thank you guys. I really enjoyed it.
And let's go ahead and thank our panelists.